So it's my pleasure to introduce Ros Rolleston. Is a primary healthcare nurse educator from the south coast of New South Wales. Currently, Ros works on outreach immunisation nurse with the Shoalhaven City Council. She's also a casual academic with the Australian College of Nursing and the University of Wollongong. So please welcome Ros.
Thank you, Matt, and thanks to everybody as well. I have to stand still because of the microphone here, so if I get a little bit jittery, you'll understand what it is, because I generally like to walk my nerves out. It's a way of covering it up, see. But the 45-year-old health assessment. Fabulous. A passion of mine, the 45-year-old health assessment, 45 to 49. I always shorten it to the 45. It's a real mouthful, isn't it? And I think, often we kind of think this is so different to chronic disease management, yet it's so similar to chronic disease management. The assessment is very similar. The process, what we talk about, is very similar. It's just that our focus here is our education is on preventing the illness, whereas in chronic disease it's about preventing the complications or reducing the impact of the complications, yeah? So, and I think if you try to look at some research around the 45-year-old health assessment, you'll come up with 1 or 2 papers that are possibly 6 to 10 years old now as well. So there hasn't been a lot of work behind the scenes on this. And if you are really passionate about the prevention of chronic illness, you want to do some research, you need to look at the prevention of cardiovascular disease in your research topics. And that will bring up a lot of international data, and there is some interesting stuff out there. So here in Australia, the facts are 97% of Australians self-identify as having at least one risk factor for a chronic illness. So to do the 45 to 49-year-old health assessment, you have to have a risk factor, don't you? That's part of it. And I always think, well, being 45 to 49 is the risk factor. But 97% of Australians already have other risk factors as well. So, I think that's really important to acknowledge. 44% of Australians self-identify as having 3 or more risk factors. These statistics are really quite alarming when we think about it, in particular when we realise that we're not putting a lot of money and effort over here in the prevention side. We're putting all of our effort over here in the management of the illness. So it's the people that are greater than 45 years of age who have the highest proportion of more than 5 risk factors. So specifically this age group that we're looking at, we really need to do some really good hard work here. 77% of Australians self-identify as having one chronic illness, at least one. That's a lot of people, isn't it? And imagine if we can just start chipping away and bringing that down. 22% of Australians have cardiovascular disease. Scary business, isn't it? And, there's so much advertising from the National Heart Foundation, AMBO's, everything. And yet people still say they didn't have chest pain, they had tightness. So they didn't feel that they were having a heart problem. 68% of people with diabetes also have cardiovascular disease and chronic renal disease. Really important when we think about these things. How can we stop this from happening? And the highest proportion of chronic illness is in our Indigenous and disadvantaged groups and our outer regional and remote areas, yep? That's the same, that's where the highest prevalence of chronic illness is. And it was important what Matt was saying, it is about closing the gap. So we have to think about our Indigenous and our disadvantaged populations in a different way that we think of everyone else. So the good old MBS, everybody wants to have a bit of a squiz at the MBS, and I think it is important. that we identify. The interesting thing when, back in 2010 when the MBS changed, the item numbers changed with the health assessments, we lost our ability to track the 45 to 49-year-old health assessment. We can only track 45 to 55-year-old health assessments. And which item number do you think is the most common of these item numbers? You can see here, of course, this is just to add, this is an ECG, this is the Spiro, Dopplers, and of course the Indigenous follow-up after a health assessment. So which health assessment item number is it that we do the most? 5? 7? 3? So we're a bit across the board here. Unfortunately, it's a 703. The 707 is the least billed item number for health assessments. Like, get down. How can you do a health assessment in less than an hour? If you're going to change things, if you're going to motivate, if you're going to, get things happening, do a complete assessment. But it is still 703. In this age group, likely that data is skewed a bit because of the 40 to 49. The AusRisk assessment as well, but still, the 707 is the least likely bill. And for your business case, it's a great one to bill, isn't it? So it's good for the business and it's good for the person. So the MBS requirements, as we said, at risk of developing chronic illness, but we know 97% of people have that anyway. It has to be the usual doctor. We need to explain the assessment, what it's all about. We need to document the consent. So to document consent, we actually have to get informed consent, yeah? So we really need to engage people when we're doing this consent. Why we're doing it, what are the benefits, what is it that they expect, how are we going to help them follow up and make changes. We need to assess the physical, psychological and social functions. This is what the MBS tell us. It's not what I'm saying, this is what the MBS tell us. We have to assess readiness for change. And this statement, this came out of the work of Professor Mark Harris from University of New South Wales. He's another one to look at his research. He's done fabulous work around the prevention of chronic illness and cardiovascular disease in Australia. Fabulous. Professor Mark Harris, University of New South Wales. He's often commissioned to write the reports to the government and stuff as well. If you ever get to see him speak, he speaks a lot on obesity, grab the opportunity because he's a really good speaker as well. And because he's researched so much around the prevention, he's just that wealth of knowledge that you want to tap into. So, he was influential enough for the government to put into the MBS assessment readiness for change. Consideration, we need to look at the consideration of preventive and education needs. So I think this is an important one as well. So education needs of our patients. Are we going to meet those needs in one appointment, even if we have an hour? And this is a key factor for the prevention of chronic illness. It's not just about one health assessment, yeah? It's about ongoing follow-up. So the further notes that come with you always go on the MBS online, click on the item number, but you always have to go to the explanatory notes as well for that item number. And then generally on that page, if you scroll down, there'll be another link which will say additional information. And you click on that link, it'll take you over to the Department of Health and give you a wealth more of information. So while we love looking at the MBS online, it's not the be-all to end-all. You've got to click on all the links to get through it. So it tells us, though, in the explanatory notes, we've got to recommend interventions and referrals, arrange investigations, keep a record on file, offer a copy to the patient, attention to risk of type 2 diabetes, cardiovascular, respiratory illnesses, cancer, arthritis, osteoporosis, mental health and renal. Can you do that in half hour? You got no chance. It's really, for me, it just kind of shows that we're not yet there for the person. Yeah? We're doing a health assessment to say that it's done, but we're not actually doing this and engaging and using a person-centred model of care. MBS funding, so here it goes, $59 for the 701, the 703 gives you $137, and yet you get $268 for the 707. Why aren't we doing the 707? It's really worth our business cases. I know I worked with one GP and she said, what would you need more than 20 minutes to do a health assessment for? What would you talk about? She had a really croaky, horrible voice like that as well. And I kind of shook my head, and, you know, the next person that came along that was her patient that I did one for, and I spent the hour, got her nose right out of joint. But I listed everything that we'd been through, all the follow-up, all you know, the ongoing organised planned care we were going to institute for this person to help them on their road. And that changed her mind. So just, you know, keep plodding and you'll get there. And of course, the 715 is the Indigenous health assessment, but we're still doing that in the 45 to 55 age group. But importantly, for this group of people, we need to take the philosophy of the prevention of chronic illness over to 35. Easy 10 years earlier. Yep, easily 10 years earlier. Okay, so what are the risk factors? Non-modifiable risk factors. These are genetic, they're family history, age, aboriginality, ethnicity, gender. Again, it's difficult, isn't it, to say you need to have a risk factor, but until you do the health assessment, you might not know what the risk factor is. Yeah? It's like the 40 to 49. You've got to do the health assessment to realise that you can't bill it. So the modifiable ones, these are the ones that we're going to work on: tobacco smoking, excess alcohol consumption, inadequate fruit and vegetable intake, physical inactivity, excessive sun exposure, insufficient vaccination. We hear about the kids a lot, don't we? What about our adults? What about Hep B? What about MMR? You know, what about pneumococcal in those at risk? All these things that might not be funded or are funded, and we need to be giving it to these people when we bring them in. What about flu? Unprotected sexual activity. We heard all about that with Sheila this morning as well. So the enablers and barriers, and what I really want you to do is have a look at these and compare the difference between, or the similarities between, the clinician barriers and enablers and the patient barriers and enablers, yep? So for the patient, the enablers are to have a family history, to have a family member that goes and says, you go to the doctor, I've made your appointment, put you in the car and drive you there. That is a really key factor. So sometimes we know this, don't we? To motivate a patient for anything, we need to bring the family in. Blood tests, PAPs, things that are physical things. They make patients feel that we're actually doing something. So they're keen to have this done. And we always like to do full screens, don't we, when we do the 45. Continuity of care, trust and rapport. Yep, trust, trust, trust. It's usual doctor, usual nurse. All patients can have a usual doctor and a usual general practice nurse. Consistency of information provided. So what I say, the doctor says, you know, the telly says, everything, not all different things. Ongoing follow-up, as we've spoken about, really important. And the written reminders. This group of people like to get a piece of paper, you know, that comes in the mail that says you need to come and see us. Yeah? So the enablers for the physicians, and I think this is really, or for the clinicians, is really, you know, we all know, it's about funding. But as we've seen, the 707 is well funded. It's about having enough time. The 707 gives us that. It's about general practice nurses, because we spend the time and we're the educators. It's about specific education programs for the general practice nurses so they know what it is that they've got to do and how they can approach the change. It's about evidence-based templates. There is not one template anywhere on the internet that has got it all there. You need to look at templates to build your one that's got it all. And it's about the referral pathways, ongoing. Barriers, perception of health. People don't realise that they're at risk. They think they're healthy, it's all right. Dad didn't have heart disease until he was 65, when in fact he had it from 45, but we just didn't know. It's about the background. It's about health literacy. I know we've heard a lot about that throughout the conference. And health literacy is not just about the person knowing what a myocardial infarction is. It's about us teaching people about illness and about wellness, yep? It's about lack of follow-up. It's about the cost of it all. If it's going to cost too much, patients not going to be able to do this. And it's lack of awareness of the health assessment. For the clinicians, you see the themes that are coming here. It's the lack of time, inadequate funding, focus on acute care, personal attitudes. The literature tells us that every different doctor does a different thing depending on their personal attitude. And that's why we need nurses to have more education, to make this a consistent assessment. And we need the referral pathways. So we're just going to quickly flick through this bit because we haven't got a lot of time left. But as we said before, these are the specific illnesses that we have to look at. Really important. And when I do these health assessments, I do take the full hour, but I negotiate with the GP what it is that they want to do. Yeah? And I don't believe that I'm, an expert in skin, so I always like my GPs, or the GP, they're not mine. I like the GP to do the skin, and that really makes them feel good and important because they think, you've done all of this, you've usurped me, but you can't do this. Isn't it great that I can? Because we've got to keep them engaged as well. It's all about the health history, the whole group, the lifestyle factors, looking at all of this, having the conversations around sexual activity, smoking, alcohol, substance use, all these things. And these are the other bits that we always include, don't we? We're really good at this, the vision. We like to test vision. We like to look at hearing, do the audiometry. Don't forget dentition. Don't forget to look at the teeth and encourage people to the dentist. Here's the gourd, the skin check. And please, please, please always ask the question, have you ever or are you exposed to violence in the workplace or home? Yeah? Please ask the question. And this is some of the papers that I've used in researching. I thought if we just put them there for you that, you might be able to, if you just even pick one of these and go ahead and read that, I'll be really very happy. Well, here's a bit more of it as well. And this is fabulous. When I had a holiday last year with my daughter in Fiji, that was the view from the room. It was gorgeous. Thank you.